in case somebody may want to rewatch this or share this with somebody, this will be posted typically in about a week onto our Brio-News website, Brio-News YouTube channel. So you check that out there, and that's where you'll find all of our previous posts. So I wanted to talk about estrogens, and that there's so much more to this story about estrogens, because when you look at hormones, it's presented as a overly simplified process as it relates to cancer, in that estrogen only applies to breast cancer. Yet there's over 30 different cancer types that we know of that express estrogen receptors alone. So this has broad impact on cancer. What I'm going to show you is it's not just about the estrogen receptors. Think of those as the front door. It's also dealing with essentially side doors, back doors, windows, and we'll talk about that in a second. It's non-genomic signaling. So who are we? We're Brio-Medical. We're here in the beautiful city of Scottsdale, Arizona, where we're headed into the most lovely time of year. Nice and warm and sunshiny and no humidity. So if you like that, come and see us here because it's fantastic. We are a natural, holistic, integrative cancer healing center here in the beautiful state of Arizona. Have patients come to us from all over the country and all over the world. Who am I? Well, I'm Dr. Nathan Goodyear. I've been treating cancer holistically now and integratively for a little bit over 5 years. I've been in the integrative movement since 2004, cut my teeth with hormones. So this context and discussion on hormones is near and dear to my heart, and I think it's one that often gets overlooked. I am an MD, medical doctor, and medical doctor homeopath. So when people look at hormones, there was a marketing campaign some years ago that was Know Your Number. It was talking about low testosterone, and if only hormones were so easy. But when you look at hormones, you have to understand, especially as it relates to physiology, but here more so with cancer, it's about having proper hormone evaluation, about knowing the hormone levels. What's the hormone balance? Because it's not just about individual levels. What about hormone enzymes? Because hormones aren't static, they're dynamic. Hormone metabolites. This is a concept of your body taking hormones and breaking them down to other metabolites that themselves have hormonal action. Hormone receptors. Hormones need receptors, but they don't need receptors to pass their signal on. We'll talk about that in a second. Cofactors. These are things involved in the hormone signaling. What are called hormone response elements, outside influences, physiologic hormone therapy, so if you're getting replacement or not, and what I like to call metabolomics. Now, metabolomics is the future here and now as it relates to many different aspects of cancer and many different aspects of disease. Metabolomics is looking at physiology through the viewpoint that it's an entire functioning biological system. And that really is at the heart of what a holistic approach is. Everybody thinks that a holistic approach or holistic therapies are natural, and that could be true, but really the concept of holistic or holism is the entire functioning biological system. And that's really what metabolomics is, which is evaluating the system. Here we're talking about estrogen and hormones in a totality functioning system, not a static system, not a number, because when you look at is a hormone high or low, this provides no connection, no impact to why or what is going on with why the level is low or high to begin with. So a person can have low estrogen, you can give them estrogen, but the reason why the body has low estrogen is because the body is trying to keep the estrogen low, and then you feed the problem by which the body has adapted. So what we want to do is we want to get away from group thinking. Was on a podcast this morning talking about that, and we want to get more at critical thinking. A lot of what's happening today is really moving away from the critical thinking to just simply recipe medicine and focusing on group thinking. Conventional medicine, of which I'm trained, targets cancer as the disease. It targets the individual as the disease harborer. It goes to war on the body because it goes to war on the cancer, and it causes massive collateral damage. In contrast, a holistic integrative approach is going to target the tumor. It's going to not target the body. It's going to work to change the environment of the body and heal the body. So the two have very different perspectives and very different approaches. So I want to introduce the concept of genomic versus non-genomic signaling. Now, genomic signaling is what's called the classic hormonal signaling. Hormone like estrogen comes along, it binds to an estrogen receptor. That receptor that's inside the cell migrates to the nucleus, and it then stimulates genetic production of proteins, what's called transcription, and then translation into proteins. Now, this has been a long-standing concept and theory behind how hormones signal, and the only. So when somebody has breast cancer, they say, well, what's your estrogen status? They're talking about estrogen receptors. This is the classic genomic hormonal signaling. But what we now know is that, guess what? That front door, that estrogen receptor, estrogen doesn't need it. Estrogen can signal non-genomically. It can signal the estrogen effect that can promote cancer without using those estrogen receptors. So when you think about that, that just really blows open the idea of just simply looking at breast cancer, or by the way, over 30 different cancer types express estrogen receptors. So if we take that out, then we're looking at a much broader perspective than just breast cancer, or prostate cancer for that matter, or ovarian cancer or endometrial cancer. But moving away from genomically to non-genomically, it can involve every different cancer type. And we'll look at that in just a second. So again, kind of a review of the genomic, or what's called the classic hormonal signaling. And if you look at that picture, you see those little triangle steroid hormones. They go into the cell, they bind to NR, and that NR then goes down and binds to that spiral DNA, and that signals a change in production from the DNA. All that other mess that you see in the cell, that's non-genomic signaling. So in fact, there's more non-genomic signaling in the cell from estrogen than that occurs with the estrogen receptors. It basically passes right through the cell, or is actively transported across there, binds to the receptors that are typically in what's called the cytosol, but it can be in the nucleus as well. It basically binds to that DNA and then triggers, again, transcription of proteins. This process is slower. It takes longer. Actually, it's been measured and estimated out to at least 2 hours. So it's a much slower process as things go. And what's interesting about this is it's very sensitive to targeted inhibition. So if estrogen receptors are present, you can go in there and try to target that in a variety of different ways. In contrast, looking at non-genomic or non-classical signaling, this does not initially influence gene expression. It doesn't initially directly influence gene expression directly. It actually activates internal cell signaling. So it can go in, have nothing to do with the receptors, and trigger all these cell signals inside the cell that, by the way, cancer will use and love and thank you for. It's very rapid. So this non-classical is very rapid compared to the genomic. It can take seconds to minutes. And guess what? You can't inhibit this process. Whereas the genomic, you can target it, but the non-genomic, you cannot. And this non-genomic bypasses many of the regulatory mechanisms involved in signaling. Now, this can be good and this can be bad, but here in cancer, a lot of this is not necessarily good. So when we look at non-genomic signaling, here's somebody from my era, can't get no respect, Rodney Dangerfield. What we're looking at over here on the left is internal cell signaling that estrogen outside of the receptor can trigger these internal cell signalings that will absolutely promote cancer growth. The RAS-RAF MAP kinase activity, the P13K AKT, these are classic pro-growth activating cell signals within the cell that cancer will just take full advantage of. Matrix metalloproteinase, this is how cancer invades. This is how cancer grows. This is also a role in what's called epithelial to mesenchymal transition, how cancer goes from immobile to mobile. SERC, oncogene activation. This is an oncogene. This triggers activation of many of these different pathways. So non-genomically, estrogen will go right through the side door, back door, windows to trigger all these signals that cancer will just take full advantage of. So when we look at genomic versus non-genomic, those two categories just simply say, hey, it can use receptors, and then estrogen cannot use receptors. But there's crosstalk, and there's crosstalk on massive scales. Non-genomic signaling, you actually see crosstalk between hormones. You'll see crosstalk between receptors, and you'll see crosstalks between hormones with different receptors that don't match. So let me give you an example of that. When you look at insulin growth factor receptor and estrogen receptor alpha. So when somebody says I have estrogen receptor positive breast cancer, they're talking about ER alpha. That's a form of estrogen receptors. These two receptors, insulin growth factor receptor 1 and ER alpha, they can actually signal each other. Now, insulin can bind to IGF-1 and insulin growth factor can bind to IGF-1. So insulin, we all know that cancer loves sugar, and insulin is the driver of sugar when glucose is introduced to the body, and insulin just is, it's like a gas pump for the tumor. So not only does this receptor, insulin growth factor 1 receptor, activate estrogen receptor alpha, you downregulate this insulin growth factor receptor, it'll downregulate estrogen receptor. Now, let me tell you why this is important. Insulin and IGF-1 are pretty predominant in their activity in many different cancer types. So if insulin, which binds to this IGF-1, about 70%, what's called cross homology, and then IGF-1 will bind to this receptor, that'll trigger estrogen receptor. So if you have estrogen receptor positive breast cancer and you're eating a bunch of Twinkies, ding dongs, and drinking Coke, that's going to drive up your insulin, and that insulin is going to drive activation of the estrogen receptor, but it does so through this insulin growth factor 1 receptor alpha. So this is massive crosstalk, but this is an example of how we can get genomic versus non-genomic crosstalk. I want to present a new topic here, what's called tumor microenvironment versus non-tumor microenvironment. The tumor microenvironment is a concept that cancer is no longer a solid ball of cells. It actually is a fluid interaction with the healthy tissue, if you will. So the tumor microenvironment is this interaction. Now, this picture gives kind of a hollow ball of cells perspective that's walled off from the body, but that is not what we now know through science and through new evidence. But what you see here on the outer loop of that is all these different cells that are involved in this process. The second layer there, outside of the tumor cells, are all these different cell signaling that can be involved in this process. And guess what? In a lot of this, estrogen signals it. Estrogen affects this tumor microenvironment. Estrogen affects genomically and non-genomically the immune system, which is so critical in the tumor and tumor microenvironment in its ability to spread. So when you look at this, what more aptly be called the tumor immunologic environment, estrogen, whether with estrogen receptors or without, will stimulate what's called tumor-associated macrophages, which are immune cells, and morph them and stimulate them to become very pro-carcinogenic. It will stimulate things called myeloderived suppressor cells, which you can see there. They will stimulate cancer-associated fibroblasts. They will stimulate T regulator cells. You can see those on the outside. What do all those do? They suppress the immune system. You suppress the immune system in the tumor microenvironment, you're going to allow and favor those cancer cells to escape and form metastasis. More so, estrogen stimulates all that in the tumor microenvironment. This is completely outside of the ER-positive estrogen receptor breast cancer. It'll also suppress natural killer cells and cytotoxic T lymphocytes. These are immune cells that are more like your Army and your Marines. We need them for hand-to-hand combat. And estrogen in this tumor microenvironment will suppress them. So the impact of estrogen, just simply looking at the tumor microenvironment through a genomic and non-genomic signaling pathway, is massive because it's affecting the immune system. And so it really blows open the idea of what estrogen is even doing. And this is just giving you some perspectives of how all of this can interact. So again, we can no longer think of tumor cells as a solid ball of cell, but it's a dynamic process. It's basically like what I talked about with metabolomics as it relates to the hormones. And when we look at estrogen, the way it's simply looked at is men are just a testosterone-fueled erection and women are an estrogen-fueled hot flash. But yet, if we just look at 17-beta estradiol, which is the most dominant estrogen in the cycling years of a woman's life, estrone being that dominates postmenopausally, all these other compounds that you see there, they're all estrogens, every one of them. And many of them actually have significant biological activity, and some of them are very pro-carcinogenic. For example, the one right there in the middle, 4-hydroxyestrone, it's really almost pro-carcinogenic, more pro-carcinogenic than the parent compound of estrone or 17-beta estradiol. So this concept of fluidity, of metabolomics is front and center reality of what's really going on here. And that includes also genomic and non-genomic hormonal signaling. And this just shows a very simple process of estradiol getting converted to estrone and estrone getting converted to estriol. By the way, estriol is the hormone that dominates during pregnancy, and estrone is, the very more pro-inflammatory estrogen that dominates postmenopausally because of its interaction with the receptor, that is the estrogen receptor. But beyond that, it can signal also without the receptor, what's called non-genomically. It's, again, really looking at estrogen in a functional metabolism perspective and not a static perspective. Can't forget about the estrogen metabolites. Here's just a list of some of them. And again, the 4-hydroxyestradiol right there, as well as the 4-hydroxyestrone, these are very, very pro-carcinogenic compounds. And so if you're going to look at estrogen, these have a lower affinity for the estrogen receptors, but they'll lock onto those receptors and won't let go like the parent compounds will. So that's from the classic perspective, but understand they don't need that front door at all. They can use the non-genomic signaling, which again is the side door, back door, top window, back window, whatever. Can't forget about the estrogen receptors. Again, when you look at, is the estrogen receptor positive or negative, we have to consider, well, there's many different types of estrogen receptors. There's estrogen receptor alpha, estrogen receptor beta, GPR30, and even a membrane estrogen receptor that's independent of any of those. And so we're dealing with a much broader perspective of how estrogen genomically can signal. But again, we're talking about it can do that, it can do it non-genomically. But again, this is a topic that we can talk for, I think a 3-hour lecture just on estrogen and hormone metabolites. So this is a much broader topic, but this dives into the genomic estrogen signaling. And so I wanted to just highlight that there. Now the membrane estrogen-like receptors, this can signal non-genomic. So we've got some receptors involved non-genomically, and we've got others that are not involving estrogen receptors. So here we're looking at xenoestrogens. So when people think of estrogen, they think of what they make. And what I tell people that surprises a lot. For men, I ask them, do you make estrogen? They're always surprised when I tell them they do. And for women, beyond menopause, they're always surprised when I tell them you're still making estrogen. So that's within the body, that's endogenous. Here with xenoestrogens, these are outside the body, exogenous source of estrogens that are from chemicals. And some of these you may have heard of: bisphenol A, phthalates, DDT, diethylstilbestrol, and of course glyphosate, which comes from Roundup. But so many of these are found in our environment, but so many of these are found in what we put on our body every day. We talk about how the home is the most toxic environment. What I would say is our body is the most toxic environment. And most of what we think of as it relates to our body is what we put in our mouth. But here, this is all showing you how many potential toxicants that are estrogenic can actually be put right through what we put on our bodies to make us look young, to make us look vital, to make us look healthy. We could actually be introducing toxins here that promote estrogens, and that can have a negative impact as it relates to cancer. And I really want you to think outside the box here, because we think about all these xenoestrogens, but here, what about metals? Cadmium is actually called a metalloestrogen. It can signal estrogenically. Of course, soy, a lot of people know about this, phytoestrogens, and then zearalenone, which is a mycotoxin. It's a fungal toxin. So a fungal toxin can actually promote estrogenic signaling. So, this is not just estrogens that we're producing. This is not just toxins we're being exposed to, but these are estrogenic signals all over the place that occur genomically via the estrogen receptors or non-genomically. So for all those biochemical junkie gurus like myself, this is just giving you some perspective of what this process looks like. And you can see that little E2 and that little bubble there outside that blue cell. That's estradiol. That's your most potent estrogen. It can go in and bind to DNA inside the nucleus, which is that inner circle. It can do so in a multitude of ways, what's called classic estrogen receptor, which is number one. It can do so by where the estrogen receptor is not directly attaching to the DNA. It can do so without the ligand. So it can do it in a lot of different ways, but that's classic genomic signaling. Everything you see outside of that inner circle, but within the outer circle, that's an example of non-genomic signaling. So this process is independent, and yet this process is interacting with each other. And so the genomic signaling, again, can occur different, via several different ways here listed. And xenoestrogens, again, these are the estrogenic compounds that we don't think about, yet they can have tremendous estrogen signaling effects. And remember, genomic signaling is a longer effect, and so it takes, about 2 hours versus the non-genomic is very quick. So when we look at the non-genomic, signaling, how does it do it? Well, it's very rapid. It's basically just rapidly diffusing through the membrane of the cell, or it's binding to a cell membrane receptor. And in so doing, it's directly and very quickly affecting internal cell signaling via things like cyclic AMP production, through things like what I showed in that previous slide, which is the SERC oncogene, the P13K-AKT, all these different cell signaling, RAS-RAF, MAP kinase, that cancer upregulates every one of them. So when you look at all these drugs that see advertised of people running down the beach with butterflies, and as somebody in the background is talking about how your left leg, your right leg, and your arm is going to fall off with this drug, though it may help you with cancer, they're targeting these many different pathways that cancer upregulates, but estrogen can signal those directly non-genomically. So you can have a cancer that doesn't have an estrogen receptor. Guess what? That estrogen is still going to be stimulating the cancer growth via these secondary signals. So here's just kind of a 30,000-foot perspective showing you just a good perspective of the process of non-genomic actions, everything that you see on the essentially top side of that cell, and everything in the center is genomic, where estrogen goes from outside the cell. You can see that with ER alpha in that darker blue circle, that's the nucleus, and binding to the helical DNA. And that's going to trigger protein synthesis. But everything else you see outside of that, that's non-genomic, estrogen. And it has massive impact that's outside the estrogen receptor. So again, estrogen is going to impact every cancer type, period. Now, if estrogen receptors are present, it's going to have more dramatic effect, but you can take it to the bank. Even if you don't have an estrogen receptor cancer type, estrogen, if overproduced endogenously or from outside, it is going to stimulate this cancer growth. And we have to recognize that if we want to really turn off all avenues to how cancer can be stimulated to grow. We want to change the environment. And here, just again, a summary of some of the cell signaling pathways inside the cell that estrogen can promote. Again, this is a deep dive because I think it's important to understand the complexity. I actually had a patient one time said, well, Dr. Goodyear, brevity is the soul of wit, right? I said, well, that's true, but we're not trying to be witty here. We're just trying to be scientifically accurate. So xenoestrogens, and again, Rodney Dangerfield get no respect. Xenoestrogens are everything we forget about, and almost all of us are getting exposed to it every day. And so for you ladies that do a lot of things to make yourself beautiful, though that's not necessary, this can really, really give you a lot of sourcing of estrogen that's beyond what your own body produces. This can increase the survival of the cell, increase calcium influx. ERK is the extracellular signal related kinase, an internal cell signal. It'll increase cyclin D1, many different aspects. Look at that, increase insulin secretion. So xenoestrogen, by the way, which is a very, very weak estrogen as it relates to estrogen receptors. So it can bind to estrogen receptors, genomic signaling. But guess what? When it does the estrogen signaling without the receptors, it becomes very powerful. And here, non-genomically, it'll stimulate insulin secretion. And if you think about that from a cancer perspective, if you're doing anything to stimulate insulin secretion, you're actually pulling up to a gas pump and inserting the gas pump and letting it pump fuel. And remember, insulin will bind to that IGF-1 receptor I mentioned earlier, and that will then stimulate estrogen receptor alpha. So xenoestrogen can directly stimulate the cancer, and it can indirectly do it through insulin receptors. And so when we look at the process of genomic versus non-genomic, our classic thought process is, these are occurring uniquely at each time. It will do it genomically, or the signaling may then be non-genomically. It's not true. It's all happening at once. These are simultaneously occurring, simultaneously independent, yet simultaneously cross-reacting and cross-talking. There's more signaling here. There's more disruption of the signaling here beyond anything that we can possibly imagine. So the crosstalk, I think, is one thing that, again, we can spend a lot of time talking about, because we think of estrogen only binding to estrogen receptors. We think of testosterone only binding to androgen receptors. But this crosstalk is massive and has huge implications as it relates to cancer. Of course, there's the genomic and non-genomic crosstalk, but crosstalk can be negative. So estrogen receptors can suppress what's called nuclear factor kappa B. This is a transcription factor that promotes inflammation. And nuclear factor kappa B can repress estrogen receptor activity. Now, each can repress each other or suppress each other, which is important as it relates to cancer, especially that NF-kappa B. But the point here is there's crosstalk. You can't just look at this as estrogen alone. This estrogen will stimulate or turn off inflammatory signaling. How about crosstalk that's positive versus negative? Because estrogen receptor suppressing NF-kappa B would actually be good here in cancer. But tumor necrosis factor alpha, which cancer loves, will enhance estradiol or estrogen activity. And estrogen activity can enhance tumor necrosis factor activity. So this is a feedback positive loop whereby inflammation will stimulate estrogen, and estrogen will stimulate inflammation, and you'll get into this vicious cycle whereby hormones and inflammation here are cross-talking, and you're developing a self-feeding system that cancer will take and run with. Crosstalk can be mutually additive, so estrogen stimulating estradiol can stimulate NF-kappa B, though estrogen receptor can inhibit it. I know it's complex, but the estradiol can promote inflammation, and inflammation can stimulate estradiol, and this will result in more aggressive tumors that lead to treatment resistance. And that's nothing we want any part of. Guess what? Estrogens can bind to dysfunctional androgen receptors. So prostate cancer, it's a very dysfunctional process where the male hormone testosterone is being used inappropriately by the cancer. Estrogens will bind to those receptors as well. So we can't just look at prostate cancer as a male hormone issue, just as we can't look at breast cancer as a female only. And what about this? Estradiol and catecholamines, such as dopamine, norepinephrine, epinephrine, these can actually promote insulin. More so, epinephrine, norepinephrine, and dopamine can actually stimulate estrogen receptors in the cell membrane. So these non-classical estrogens hormone receptors that are in the cell membrane, they can actually be stimulated by epinephrine and norepinephrine. You may also know these as adrenaline and noradrenaline. These are part of your stress response. This is why it's so critical to understand what's going on with the totality of your hormones, not just all of your estrogen and estrogen metabolites, but all the male hormones, the progesterone, the cortisol and cortisol metabolites, all the neurotransmitters, because there's so much crosstalk going on that you get this crosstalk in cross tissue, and we start to develop this environment that is just going to cause a cancer to explode. So, the food for thought here is that this concept is much far beyond breast cancer and estrogen, testosterone and prostate cancer. Estrogen is crosstalking on massive fronts here, with each other, with other cancer types, genomically, non-genomically. I mean, look at that, 3-alpha androstenediol. I don't know who comes up with these names, but they ought to be put in a corner or something. But 3-alpha androstenediol is a male hormone metabolite. It's one of the more potent male hormones. It binds to estrogen receptors. So here's a male hormone that can stimulate estrogen receptors. So can insulin. And norepinephrine and epinephrine can stimulate that. Dopamine can stimulate that. So if you're taking a lot of neurotransmitter modifiers, so antidepressants and these kind of things, these can stimulate and promote all this internal crosstalk that can involve estrogen via genomic or non-genomic signaling. So the tumor microenvironment and the non-tumor microenvironment, this is actually a picture of the tumor microenvironment. Now that solid ball of cells, that's obviously the solid tumor. But when you look in the lower part of that, you kind of see a blurring of that process. That is the tumor microenvironment. And this is really the future of the process of cancer that we're looking at here and now. And it is within this tumor microenvironment that is well beyond the scope of the way estrogen has been classically viewed, that estrogen is actually having a huge impact on the immune system, on how the cancer can invade, how the cancer can spread, but it does so genomically and non-genomically in the tumor microenvironment affecting the immune system. So what do we got to do? We got to change the environment. We can't target the tumor. A holistic integrative approach has to approach this process by understanding we need to change the environment, because by changing the environment, we're going to change the signaling that comes from that environment. This is just a study, and I know it's I don't mean to make it too technical, but what it's showing is it's showing you the hardcore science here that's showing that the environment is reprogramming the immune cells, here macrophages. So the environment in and around the cancer is reprogramming these immune systems. That's exactly what estrogen does genomically and non-genomically. It's reprogramming it. And it's doing so in not just in estrogen positive receptors in breast cancer, it's doing so in non as well, in the same manner. We must change the environment. We must heal the environment. We can target a tumor, but we have to heal the environment. And in that healing of the environment will really affect and change all of this dysfunctional signaling or communication that cancer is taking full advantage of. So the impact of estrogen is that it's genomic and non-genomic signaling. Both exist and they coexist simultaneously. There's massive crosstalk between this genomic or estrogen receptor signaling, but also through this non-genomic. So the estrogen is going to apply to all cancer types, more so in the tumor microenvironment, but in all types, in all areas. The primary 3 estrogens, E1, E2, E3, and the associated estrogen metabolites are going to participate in both the genomic and the non-genomic signaling, but also in the crosstalk. There's much, much broader estrogen interaction with other hormones. And likewise, there's other hormones and other receptors, interacting with the estrogen receptors. The environmental influences of this signaling response, the xenoestrogens, the mycotoxins, all of these things, the metals, particularly cadmium, these are all impacting the exposure issue as well. So we can't just look at this as estrogen. We have to consider all of the environmental or outside toxins called toxicants that can also be involved here. That's why you have to look at environmental toxicant testing in anybody that comes in with cancer. People go, well, I don't have estrogen, an estrogen responsive tumor. Why do I need to look at my hormones? Why do I need to look at all these environmental toxicants if I'm not worried about toxic levels or their impact as hormones? Guess what? It impacts all different types of cancers. And that will do so via genomic and non-genomic. And then we can't forget about all the massive crosstalk here, specifically talking about, things like epinephrine and norepinephrine and dopamine actually binding to the estrogen receptors to actually signal estrogen signaling. Now that would be via the classic, but then you can also have non-classic signaling. So when you look at estrogen, when you look at cancer, it's not just about those estrogen receptors, which is the non-genomic signaling. It's also about all those other ways that estrogen can get in that cell, get in that environment that is in the tumor microenvironment and change the communication that favors the cancer. But it's even beyond the estrogens. It's neurotransmitter, other hormones, even male hormones that can get involved in this process. So this was not necessarily to focus on what to do. It was really to just take a step back and say, we need to understand the full complexity of hormones as it relates to all cancer types, not just estrogen receptor positive breast cancer. So here at Brio, you want to get in touch, give us a call. There's a number, there's our email, there's our website. I definitely recommend you check out our website. And as a patient here, all new patients, we're going to evaluate your hormones. We're going to evaluate your hormone metabolites. We're going to evaluate your neurotransmitters, your stress response, your environmental toxicants, such as the phthalates, the glyphosates, the metals. All of these are involved in this genomic and non-genomic hormonal signaling. And to change the environment, to maximize healing, and to hope to achieve that no evidence of disease, all of these are required to help us to target every aspect of this miscommunication that is the environment of the cancer and the tumor microenvironment. So I hope this has been helpful. It's a deep dive, I know, but I hope it really shows the complexity of how we need to approach cancer to affect a change and heal the body. So let's see what kind of questions we got here. And let's see if I can, there we go. Okay. How do you use this information in treating the patients with cancer? That's a great question. We want to change the environment. So what I tell our patients is holistically and integratively, we don't want to just target a tumor. So we don't want to just go after a headache with a 2x4. If there's an obvious tumor or location we can target, we do. We have to change the environment. Cancer is an adaptation to an inhospitable environment. And the point of all of this, talking about the genomic, non-genomic signaling, the crosstalk, is it's talking about all the massive miscommunication that occurs. And we know this in relationships. The biggest issue why relationships have struggled is miscommunication. And what we're seeing here in this context and this concept is the miscommunication. Here, it's much more than just a damaged relationship. It's a damaged body. It's something we call cancer. So it helps us to really focus on healing and really targeting this process from a totality or holistic approach. Can you tell me about the therapies you use at Brio to treat cancer? Yeah. So, let's just focus on this from a hormonal perspective. We would look at the hormones. We would integrate with very targeted therapies, a lot of it natural and holistically to improve estrogen metabolism. We'd look at the stress response. We would target that stress response to keep that from being involved in estrogen signaling, both genomically and non-genomically. That could be medications, some targeted medications. A lot of it would be natural. Of course, we have many different IV therapies that we would employ, and each one of them has a specific individual purpose. So we've had 2 previous webinars where I talked about IPT, which is low-dose metronomic chemo, a form of it. We talked about high-dose vitamin C. We have many other different treatment areas. I mean, resveratrol, which can be given IV, it actually can get into the tumor microenvironment and downregulate this estrogen signaling that's suppressing the immune system. Hyperthermia, which is where we're using heat to mimic a fever. Immunotherapy with things like mistletoe, with things like peptides, and peptides can be used for direct cancer killing effects. We have hyperbaric oxygen. We have many different therapies that we bring together. Not that everybody needs every therapy, but we want to have all of those treatment therapy and options available to us to use together, use in sequence to target specific aspects of a cancer, and that's unique to each cancer type, but unique to each individual. How long can you stay on estrogen blockers? Great question. Is it better to have estrogen positive breast cancer? Let me start with that second question first, excuse me. And when you look at estrogen positive breast cancer from a growth perspective, it's slower growing. So from a prognosis, if you compare it to estrogen receptor negative, or which can be associated with triple negative breast cancer, it tends to be a much slower growing breast cancer compared to the estrogen negative. Now, that being said, when estrogen receptor positivity is present, it does point to spread. So it is a slower growing, it is a less aggressive, but it still points to the ability to spread. So the best answer to breast cancer would be to not get it, obviously. The best answer beyond that is to catch it early. And if you had to say, well, between the two, if I had an estrogen receptor negative or an estrogen receptor positive, which has a better prognosis, a slower growing, that would be the estrogen positive breast cancer. Now, how long can you stay on estrogen blockers? Well, there's different types of estrogen blockers. What we try to do is be very targeted in what we're doing. So for example, I'm a big fan of aromatases, aromatase inhibitors. Now I know that a lot of conventional docs, oncologists won't use that as much, but understand there's lots of studies looking at aromatase inhibitors in the tumor microenvironment, which my opinion is that is the future here and now of where the activity is in tumors. That is where cancer invades. That's where cancer sends out satellite cells. That's where cancer escapes the immune system. And so how long can you stay on estrogen blockers? Well, as long as we need to. Hopefully we can move beyond medications and move to a more natural perspective, which can be done, but we need to change the environment to make that transition. This is why it's so important to target a tumor and do so in the beginning with drugs and hormones and if we need to with drugs and hormones, but with natural therapies, but we need to change the environment. By changing the environment, we can bring together this integrative approach so that we can move away from these therapies and actually let the body do its job, which is heal. What cancer types other than breast cancer are impacted by xenoestrogens? Well, I've kind of touched on this, but probably a lot of them, and most of them, if not all of them, because xenoestrogens can bind to estrogen receptors, which is inside the cytosol of the cell and inside the cell nucleus, but it can also be very aggressive as an estrogen signal, not binding to estrogen receptors. And so xenoestrogens are going to affect most cancer types non-genomically. But if you have an estrogen receptor positive breast cancer, it's absolutely xenoestrogens are going to genomically or directly bind to those estrogen receptors. And that's going to be in your classic kind of breast cancer, ovarian cancer, uterine cancer, these type of cancers that are classically hormonal. And yes, prostate cancer is included in that as well. How do you test and identify the toxins that cause disturbances with estrogen levels? I kind of touched on that, so it's a good question. You got to look at, you can't just look at, my perspective is you can't just look at estrogen in blood. It's just that is such a static perspective. It's not functional. It provides no dynamic perspective at all. So the way I like to look at hormones is just on the basic hormones is look at them in saliva. I like to look at hormone metabolites in urine. A good friend of mine, David Zava, probably nobody more researched on breast cancer than him. Started a lab company many years ago. And these are two tests that we use there. Environmental toxicants is via another test. And then neurotransmitters are very helpful here, which is a part of the stress response as well. So I bring these 4 specialty kits together and I use them to really look at the environment. We're looking at, okay, what's the degree of the miscommunication here? And how do we work through this? How do we target it from an integrated perspective to holistically look at this as a whole organism to start the process of healing? Change the environment, you change the signaling. How does your treatment cure prostate cancer? Well, let me back up, and the word cure here, I think we have to be very careful of. I would say that there's no doctor that can cure disease, prostate cancer. I think what you can do is you can focus on helping the body heal. I mean, we have a gentleman here right now that came in with prostate cancer and his PSA is now normal. And he's doing fantastic. His PSA continues to drop through the normal range. What are we doing? We're doing a very targeted hormonal therapy that is interfering with how testosterone binds to the testosterone receptor, the androgen receptor, but we're working in all the other hormonal environment, the metabolites, we're doing so naturally. We're working in the stress response. All of these we know impact the hormones, but impact the immune system. Guess what? We're changing the environment of his body. He's losing weight in a healthy way. So he's well over 200 pounds. Now he's down in the 190s. His insulin levels have dropped. His inflammatory response has dropped. This gentleman is getting healthier. And he just so happens to have had 4 pacemakers placed, multiple bypasses of his coronary arteries. So the changes we're making to improve the signaling and miscommunication associated with the prostate cancer is making him healthier from a cardiovascular perspective. We're changing the environment. So we're doing so there with a pill, with some IV therapies, vitamin C and artesunate or artemisinin. These are natural therapies, IV together, very effective against prostate cancer, by the way. And we're combining this in a multi-prong approach with nutrition. And this gentleman is doing great. He's doing fantastic. In fact, I told him the other day, I said, look, your heart's your biggest issue now. Your heart is your biggest issue. But what you're doing for your prostate cancer is working for prostate cancer, but it's working for your cardiovascular disease as well. How do you feel about the use of Piqray and fulvestrant in treatment of invasive ductal carcinoma with metastasis? Well, some of these drugs are pretty strong, pretty powerful. Now, fulvestrant, also known as Faslodex, really, it's down-regulating estrogen receptors. Piqray is an inhibitor, tyrosine kinase. So these are powerful drugs. I'll use Faslodex from time to time when we're not getting really good response from the aromatase inhibitors, or when you look at the initial pathology where they look at it underneath the microscope and they stain it, and there's massive estrogen staining. So in those instances, Faslodex or fulvestrant can be helpful. And so I'll use that from time to time. Let me tell you what, that injection, I've never had it, but for the patients, it hurts like the dickens. Fulvestrant can have a positive effect with aromatase inhibitors like letrozole and anostrozole. Natural therapies there would be chrysin and myomin, a lot of the polyphenols, and they have a positive effect in the tumor microenvironment in the immune system. Piqray, that's working in that internal cell signaling that I referenced, how estrogen can non-genomically signal, that process. So when you have maybe a cancer type that's recurred, a cancer type that's showing itself to be very aggressive in growth potential, one that stains very positive, one tumor or disease process with breast cancer that's very spread, you could step in and be very aggressive, like with these therapies, the Piqray and the fulvestrant or Faslodex, but you can add other therapies with this to make it a full, complete, integrative perspective, because these aren't going to do anything to change the environment. These are like throwing a monkey wrench into the machine, the internal cell machinery. It's not changing the environment. That's a part of that miscommunication. We have to change that as well, because it's through that change in that cell signaling, that communication, that you're going to lessen the need for all this miscommunication and these direct targeted drugs that are associated with some pretty significant side effects, trust me. So if you have broad spread, spreading disease, very aggressive, out of the gate, these can be therapies that'll be helpful, but I think as standalone therapies, that is not the answer. Again, going to war on the body is going to create massive collateral damage. We want to be targeted, we want to be directed, we want to aspect all degrees of this miscommunication. We want to change the environment, because it is the environment that changes the signaling. And we need to affect that change, because that's going to lessen the need for these other therapies. Is there a special diet you put cancer patients on? Yeah, this kind of goes back to another topic we could talk about sometime about the gut microbiome, the bacteria in the gut. Everybody focuses on probiotics, but they've actually done studies looking at dietary intake and how that affects the body. And there was actually a study where they looked at what's called microRNA, which are small pieces of RNA, which is DNA is encoded to RNA, and then that goes on to become a protein. But they actually did a study looking at broccoli microRNA, and they basically followed it all the way from food through the gut into the systemic circulation to actually affecting a change in estrogen metabolism. Now, what we know about a plant-based diet, which obviously broccoli is a plant, grows above the ground, this is a great source of boosting healthy gut bacteria that we know have an anti-cancer effect, like the group called Bifidobacter. And what we know about conventional medicine research is that chemotherapy, full dose now, and radiation with an optimal, strong Bifidobacter species or family group of bacteria in the gut, you're going to get better treatment effects, cancer killing effects, and less side effects by having an optimal Bifidobacter group in the gut. So it's a treatment. It's an adjuvant. It's going to augment conventional chemotherapy. It's going to augment radiation. So if we're using low dose chemotherapy, guess what? A plant-based diet supporting Bifidobacter is going to support that low dose metronomic chemo. But more so, there's research that shows it's going to reduce inflammation that arises from the gut that plays a role in the cancer process to begin with. It's called metabolic endotoxemia. So what I tell people is health or disease, it begins in the gut, because it has such a systemic effect, but it's so broad in how this happens. But it can do so in many different ways. But a good plant-based diet is a general key step to how you work to change the environment, how you work to reduce inflammation, how you work to reduce the miscommunication that I've just highlighted in all this estrogen mess and estrogen and hormone miscommunication. But plant-based diet is going to be key to that. Now, there's some variations to that, but if you look at a good plant-based diet, research shows that's going to support good healthy gut bacteria, that's going to reduce systemic inflammation, and that's a good foundational tool. as it relates to cancer treatment. What about Lupron for stage 4? Not sure, 4E plus ILC. I'm just going to assume you're talking about stage 4, maybe a typo. Estrogen positive. Okay. Yeah, Lupron. Lupron is a drug that shuts all estrogen production down. Okay, so I think I'm not a big fan of that drug. I've seen it cause multiple sclerosis. I've seen it cause seizures. It's a tough drug. It's a tough drug. But I think when you look at Lupron as it relates to cancer, particularly here in the situation you're presenting, the concept is, and I think it's flawed, they're saying, well, the estrogen that's stimulating the cancer is only coming from what I'm making. And so with Lupron, I got to shut it down. Now, that is implying that the only estrogen that's being produced is coming from the brain, the pituitary, the hypothalamus, stimulating the ovaries to produce estrogen. That in a woman with estrogen-responsive breast cancer, that's where it's coming from. Well, beyond menopause, which I don't know if you're menopausal or not, most estrogen comes outside of that stimulating pathway. Comes from the adrenal glands, comes from abdominal fat. In fact, beyond menopause, most estrogen comes from abdominal fat. Everybody looks as, abdominal fat is an unsightly thing, but it's really a hormonal inflammatory producing factory. So Lupron's not going to have any effect there, none. So it's not going to target all of the estrogen. The other thing, it's not going to target any of those outside estrogens that are, I think, a bigger role, get no respect, Rodney Dangerfield role on cancer. And so this is all, I think it's too narrow of a perspective. Now, Lupron can be helpful in the short term, but again, I like to be more targeted because Lupron is associated with massive side effects, poor quality of life issues, and I like to be more targeted in the estrogen receptors. But if you take a very narrow view and just say, well, estrogen receptor positivity, Lupron, you can see how that would make sense. But if you actually look at hormones as it relates to what our understanding is about how hormones in the environment really work together to create miscommunication and crosstalk in the tumor microenvironment, and in other tissue types, the Lupron is not even coming close to hitting the nail on the head. We have to look much broader. We have to be much more targeted. We have to work to change that entire environment. So I know it's kind of all over the map with that discussion, but it's a tough drug. It's a real tough drug. And I think it misses the boat on how and what we really know about hormones, particularly the estrogen metabolites, crosstalk, genomic, non-genomic, et cetera, what we really now know about how it affects cancer. Look at that, 5:59. Awesome. Well, I did a podcast this morning, webinar now, saw patients today. So I hope everybody got a little bit out of this. The complexity here and the broad perspective is what I think is really important. And this webinar we'll post in about a week or so. So if you want to, re-listen to it, I encourage you to check that out. We'll have more information coming in the near future, diving into more details as it relates to these items. So I hope this has been enjoyable. I hope everybody has a great evening, a fantastic Friday, and a wonderful weekend. And I hope your healing journey is something that is strong and long, and you have many, many years of healing in the future. And that's what cancer is not something that has no hope. It's a word that rips the hope out of most people. But by taking this targeted approach, by understanding the research and diving in, there's hope. There's absolutely hope. There's real hope, not false hope. There's real hope. And it's this science that's showing us and guiding us how to do it. It's giving us the wisdom to apply it. So I hope everybody has a great weekend, and God bless to you all.